about your endocrine disorders and the management that comes with us nurses taking care of these patients. So we have our thyroid gland disorders. Some of you have already had, an information about this one, but for many of you who still have not read regarding your thyroid gland, so this is just going to be a recap of what has been discussed last week. So you have, yes, these are your thyroid hormones, your T3 and your T4, your triiodothyronine and your thyroxine, which are both needed for, actually, to synthesize these hormones. Your iodine is a very important or significant factor for the synthesis of these hormones. Without your iodine, the T3 and your T4 would not be secreted and released into your circulation. So your thyroid gland is actually controlled, the release of these thyroid hormones are actually controlled by your TSH or your thyroid stimulating hormone. And your T3 and T4 is very much responsible for your cellular metabolism, your brain development, normal growth, and whatever metabolism that affects the organs of the body. So it's basically metabolism equals thyroid hormones. And yes, your T3 is 5 times as potent as your T4. Well, that's just for your FYI. Now, let's move on to the discussion of your thyroid gland disorders. Okay, but before anything else, this I have discussed and I have lectured to you last week regarding the diagnostic procedures. This is your radioactive iodine uptake, which measures the rate of iodine uptake, how well your thyroid glands are able to absorb, or there is an uptake of your iodine. If, for example, there is a high uptake, what it means to say is that your glands are hyperactive. So you are going to expect that with a high uptake of your iodine, it means to say there is your hyperactivity of your thyroid gland, hence your hyperthyroidism. And if there is your low uptake of your iodine that is administered to you, then therefore it would mean that the patient has a hypoactive thyroid gland, hence your hypothyroidism. So the picture on the right side shows to you the thyroid scan results, okay, for determining the size, shape, and size of the gland. So when you have your hot areas, as you can see on the first picture, hot areas would mean that there is your hyperactivity, there is increased function of your thyroid gland. Therefore, you're going to assume that that is your hyperthyroidism. And on the right side, the second picture shows to you a cold nodule with your thyroid scan, and that would mean that these cold areas is considered as a decreased function of your thyroid gland, hence your hypothyroidism. So both of these pictures, or these scans from the machine, would provide enough information if the client is indeed suffering from either hyperthyroidism or your hypothyroidism. Okay, so the etiology of your hypothyroidism, so we're talking about hypo, so there's less of your thyroid hormones being secreted or circulated in your system. So if there is less of your T3 and your T4, then you would understand that there will be a decrease in your basal metabolic rate. Everything just slows down for the patient who has your hypothyroidism. And the decreased synthesis of your thyroid hormone in the adult, okay, is usually a result of your hypothyroid state and usually associated with your primary and your secondary type of your hypothyroidism. The first one would mean that your thyroid gland, that's the culprit there. It's not just making enough of your thyroid hormone. Therefore, your body would react to this negative feedback that there is less of your thyroid hormones being secreted. So it will be your trigger factor to tell your TSH to be secreting more, so that it will, your TSH will actually tell your thyroid gland to release your T3 and your T4. However, since the problem here is your thyroid gland, no matter how high or elevated your TSH levels would be, it would still not be enough to have your thyroid gland secrete your T3 and your T4, because it's your thyroid gland that's having a problem here. So even if you have that triggering factor of your TSH elevated levels, it will not help at all. Your secondary thyroid hypothyroidism is again a result of that increased levels of your TSH, which stimulates your fibroblasts in your skins and your soft tissues to actually tell your thyroid gland to do enough or make enough or produce enough of your T3 and your T4. But still, since the problem again is your thyroid gland, and with the elevated TSH levels still continuing to be like that, it's still not going to reduce your T3 and your T4 because, again, let's go back to the very culprit of the disease. It's your thyroid gland. So, your hypothyroidism occurs primarily in older age group and 5 times more common among women than in men. So, usually the patients that we handle in the clinical area, in my experience, most of them are women. I think I've handled only your hypothyroidism, maybe 1 or 2 men, but mostly it's the women. Okay, it's the women. So these are the manifestations that are being seen on clients who have your hypothyroidism. So I've drawn this one last week. You have your hypothyroidism. Because number 1, we have cold intolerance. There you go. Kasi nga, walang heat. There's no heat system that will accommodate the cold temperature or the cold weather that is being subjected to the client. So, without that metabolic rate, the client would not be able to overcome that cold sensation. So, that's why we have your intolerance to cold. As you can see in the picture, your patient has, he's covered from top to bottom. We also have your receding hairline. Again, you can attribute all of this to your very, very low or slow metabolic rate, your facial and your eyelid edema. We also have your dull black expression, your robot face, mask-like rigidity, extreme fatigue. Kasi nga, nag-slow down lahat. Metabolism is just very, very slow. So, movement requires so much of your energy. So, in this case here, because there's not enough metabolism that's ongoing, then therefore there's not going to be enough energy also for the client to exhibit. We also have your thick tongue or their slow speech. For that matter, anorexia, there's less of your appetite to eat. And then, there's just not much energy to actually eat. You have your brittle nails and hair, again, as a result of that slow metabolic rate. Again, there's your hair loss, there's your apathy, blank face, dull expression. There's lethargy as a consequence of that slow metabolic rate. Dry skin, aside from having your brittle nails and your hair. There's muscle weakness, muscle aches. And there's also constipation as a result of that slowing down of your peristalsis. Again, secondary to that slow metabolic rate that's happening in your GI tract. Menstrual disturbances will also be associated here. Your late clinical manifestations, if there is your non-compliance to medications, even if you know that you need to take the medicines, complications for this one will be, these late clinical manifestations, such as your subnormal temperature. So, it's not just going to be intolerance to cold here anymore, but having your subnormal temperature, like 35, 34 degrees centigrade. You also have your bradycardia. Yes, you can associate that with the slow metabolic rate. You also have your weight gain. Kasi nga, since very slow yung metabolic rate mo, you're just going to be gaining a lot of fatty tissues, your muscle mass, not even muscle mass, but mostly your adipose tissues, because you're not moving much. You have muscle aches, muscle weakness, and probably as a client who has your hypothyroidism, you're just too weak to move around. So you have your weight gain. There will be LOC changes as well. And you have your thickened skin, again, attributed to your slow metabolic rate and your cardiac complications. Okay, because you have there your bradycardia. So, when you're going to think about your heart activity, it's going to be affected as well. So, you might be thinking arrhythmia or maybe atherosclerosis because, again, slowing down of activity, slowing down of your metabolic rate. So these are your manifestations for your hypothyroidism. So what can you do for patients who have your hypothyroidism? If you know that the very reason why the patient is suffering from the disease is because he is lacking something, and in this case, your T3 and your T4, then your interventions will be associated to the administration of what is missing. So that means you're going to provide your thyroid replacement therapy. Okay, initially, the doctor is going to give you small dosages until such time that the client will achieve a stable status. So the doctor would deem it important that there will be increase in the dosage. So an example of that is your Synthroid, your levothyroxine, as you can see in this picture here. Okay, so usually it is individualized in dosage because not everyone has the same responses. So again, we're talking about your hormones here, and when you're thinking of hormones, it's fluctuating and it's just not the same for all. It's very individualized. So the doctor needs to, check the patient history, check the patient's responses. And as a nurse who will be facilitating the administration or maybe the reminding of the patient to take the medication, you also need to be familiar with the manifestations and the responses of the patient after the thyroid replacement therapy has been given to them. So we have these thyroid hormones, okay, supplementary hormones, if I should say, your levothyroxine or your Synthroid. You also have your triiodothyronine, okay, and then you have your Leotrix. So if you cannot remember your generic names, you can remember your brand name. So you have your Synthroid, your Cytomel, and your Thyrolar. So these are your thyroid replacement hormone medications. Give what is missing. That's the basic interventions that we can provide to our patient. Okay, so since again, thinking about your hormones, everything is just fluctuating in several scenarios. So it is very important that we have to achieve your homodynamic status, and in doing so, we need to have your maintenance evaluation of our patient, trying to find out if the medications are working fine or if there are any errors or if there is, some problem with the administration or maybe the response of the patient. So screening every 5 years after the age of 35 for your thyroid hormone status is very, very important. Okay, so these are our client education to our patient who has your hypothyroidism. Another intervention would mean that since everything is slowed down, it is important that the client needs to complete activities, and we have to facilitate that. You do not treat them as somebody who is, disabled or debilitated. It's just that everything that they do is slowed down. So allow the client to complete the activities, and don't do it for them. Make them do it for themselves. Provide warm environment because, there's your intolerance to your cold. So you provide your extra blankets, your jackets, your socks for that matter. So anything that will provide you warmth in situations where the client thinks that there is your cold sensation. So provide meticulous care because we have your dry skin, brittle nails. You also have your coarse skin. So prevent constipation also. How are you going to do that? High fiber diet. You have your OFI, increase OFI. This will facilitate, the defecation of our patient. Orient client to time, date, place, and person. So this is to check for your LOC changes. We don't want the clinical manifestations to happen to our clients. So it is important that as nurses, we need to observe each of these responses coming from the patient. Now, if in any case there is your complication, because the worst case scenario for your hypothyroidism is your myxedema coma. It's putting a client in a comatose state because there's just not enough of your T3 and your T4. So if we don't want that to happen, we need to avoid that one. It is important that as nurses we need to monitor your vital signs. Well, that's already a given. However, apart from that, you need to monitor also your AVGs, your arterial blood gas, your pulse oximetry should be at bedside, and your oxygen administration should also be at bedside because we would like to avoid the incidence or the complication of your myxedema coma. So again, this is your reading homework. I hope for some of you have read this one because that might be included in our quiz tomorrow. Okay, so myxedema coma and your Hashimoto's thyroiditis. Okay, let's move on. So we're done with your hypothyroidism. Let's move on to your hyperthyroidism. So it's the exact opposite of your hypothyroidism. So this one has something to do with the increased synthesis of your thyroid hormone, just so much levels of your T3 and your T4 in your system. And yes, much more obvious ang ating hyperthyroidism because you can see that there are your ocular signs, eye bulging. You have your diffused goiter, as you can see in your neck, under your neck, And it's also called as your Graves' disease. So, it occurs 4 times more frequently in women. I think ang mga babae talaga is the female population who has a high attribute to suffering from your thyroid gland problems than your men. So, it usually occurs between 20 to 40 years of age. Okay? And it's also called thyrotoxicosis and your Graves' disease. And that's it. This is for the etiology of your hyperthyroidism. And then, what causes your hyperthyroidism? You have 1, 2, 3, 4. I've mentioned this to some, and for those who have not yet, have not yet been informed, I am going to tell you that your Graves' disease is the most common cause of your hyperthyroidism among your population affected by this disease, and it's usually caused by your autoimmune disorders. So I don't need to delve much on the principles of your autoimmune disease because it has already been discussed to you in NCM 112. You also have your thyroiditis from the term or the suffix thyroiditis, so inflammation of your thyroid glands. Therefore, with that abnormality and your edema in your gland, you will also have an anticipated increase in your thyroid hormone production. So that is your thyroiditis. Next, you have your overactive thyroid gland. So the problem here and the culprit here is your thyroid gland. Sobrang pabibo, si gland natin. So apart from having an inflammatory reaction in your thyroid, it can also be, manifested in 3 different ways, like subacute. You also have your postpartum and silent. The silent one is rather, insidious in nature because the hyperactivity of the thyroid gland there is constant but is low. So, compared to your postpartum actually happens after your delivery. And you have your subacute, which is, it manifests itself in ways and means wherein, rapid, no, not rapid because rapid is acute, but subacute is like, it's in between. It's in between your chronic and your acute stage or acute phase of your hyperthyroidism. And then silent, initially you will think that you're okay, but actually, and you think that you are, losing weight. You think that you're fine, but when you have your medical examination, you find out that, oh my gosh, you have very high levels of your T3 and your T4. And that weight loss is not actually caused by your diet or whatever, not even your metabolic. Caused by your metabolic rate, but it's the abnormal metabolic rate that causes you to have that, your weight loss. So you can consider that as your silent type because it's slow and it's insidious. And when it happens, boom, you have your hyperthyroidism there already. And then you have your increased thyroid hormone medicines. Because of your medication administration or your intake of your hyperthyroid medications. Remember, your hormone replacement therapy, when you have an overdose of that, or when you have your over replacement of your thyroid hormone as a supplement, then you are going to have to experience the side effect of having hyperthyroidism. Okay? So that is your increased thyroid hormone medication as one of the reasons or the causes for having a hyperthyroidism. Okay, nagets ba? Next, let's move on. So, yes, you also have in your laboratory findings, you might have your decreased TSH kasi there's no need for the body to have an increased TSH level here considering that we have elevated levels of your T3 and your T4. So, as you can see, there is increased free T3, the circulating T4 pala. And then you have your increased radioactive iodine uptake because, again, your iodine is very important in the synthesis of your thyroid hormones. So, since hyperactive yung ating thyroid gland here, at since madami yung nailalabas na thyroid hormones, masyado ding marami ang radioactive iodine uptake. Okay, because there's that need to synthesize your thyroid hormones. Okay? Next, let's move on. So, your signs and symptoms of your hyperthyroidism are the following. If in your hypothyroidism you have intolerance to your cold, your hyperthyroidism, yan. I think drawing ko na ito natin sa inyong, ano to pharmacology. Yes, hyper. This means that there is, you have your tremors. Ayan. You have your tremors. Kaya ganyan ang itsura niyan. And you have your tachycardia. Everything is just going fast because this is hyperthyroidism. Associate your hyperthyroidism to increase high levels of your metabolic rate. Okay, so you have your facial flushing, you have your enlarged thyroid. Okay, anterior, in your neck, you have your enlarged thyroid there. You also have your bulging eyes. We call that one as your exophthalmos. Okay. Okay. You also have your fine, straight hair kasi nga, masyadong mabilis yung metabolic rate mo. Unfortunately, with your hyperthyroidism, you have intolerance to heat. Everything is just too warm for you. So you need a cold environment so that you can overcome that warm sensation or hot sensation. Next, you also have your systolic BP, which is elevated because nga, lahat nga mataas. Everything is just up. So you have tachycardia, you have your increased systolic BP, you have breast enlargement, you have your weight loss, you're losing a lot of weight here because of that increased metabolic activity that's happening in your system. Muscle wasting will also be associated to that increased metabolic rate. Menstrual changes, amenorrhea can also happen. Diarrhea, yes, because there's hyperactivity of your peristalsis, okay, the muscles in your GI tract. And again, we can associate that with your increased metabolic rate. You also have your finger clubbing, you have your tremors I've mentioned, and localized edema on your lower limbs. Okay, that is your hyperthyroidism manifestations. That is your goiter, and this is your exophthalmos. These are very common manifestations. One look at that, okay, you know that, oh, the client is suffering from hyperthyroidism. Okay, that is the manifestation. Next, so what are we going to do? Your interventions for a client who has this disease. So we would like to minimize stress-producing situations as much as possible because this might actually aggravate further your patient's case and, might proceed more to increasing your metabolic rate. You don't want to do that. Ang goal mo dito is to try to slow everything down because everything just happens too fast. Your metabolic rate is just very high. So your intention here or your goal is to actually slow it down. So, in that case, we need to avoid stressful situations so that we slow down your metabolic rate. We also keep your room cool because you are intolerant to your heat. So, we provide your patient with your uninterrupted rests, provide diet which is high in calories because you're losing a lot of weight here. There's muscle wasting. Again, as a result of that increased metabolic rate, so we have to provide them calories, we have to provide them proteins, we have to provide them your carbohydrates, for that matter, and even enough supplemental feedings between meals and even at night. Again, kasi nga, nauubusan ka na ng tissues. I mean, there's muscle wasting, you lose a lot of your weight. Nutrition-wise, it's going to be a problem here because of that increased metabolic rate. So, you need to do something about that. Next, protect eyes from, from dry environment, considering that the pads of your orbits, not your orbits, but yung mismong eye mo, your eyeballs. When the reason why our eyeballs are actually working or even our eyes are actually working is because you have moisture there. That's why we blink every now and then. But it's not going to be the same for people who have your exophthalmos. Kasi nga, nag-bulge. Yung pads ng ating eyeballs dyan, it has protruded outside of your orbits. And that would predispose the patient to having your dry eyes. And having a dry eye will predispose again or make the patient susceptible to your ocular injuries. And we don't want that to result from the negligence of us nurses not being able to take care of them. So what we can do for the patient is to provide your eye patches or maybe even your tinted eyeglasses because the patient might also be suffering from photophobia here. Kasi nga, nakalabas na yung mata niya. Okay, there are several degrees or levels of your exophthalmos. I've seen in the clinical area, talagang sobrang laki yung mata niya. And it doesn't mean that if you have a huge exophthalmos there, you can see better and clearly. No, it's the exact opposite. So we need to provide interventions for that one. So patches, tinted eyeglasses, cool compress. on the orbits of the patient, having your exophthalmos. Next, okay, intervention. Ang reason kung bakit meron tayong hyperthyroidism is because something is wrong with your thyroid gland. So, even if you provide, all of these medications, it's still not going to be enough because the root cause of the problem is your thyroid gland. So, what we can do for the patient is to actually remove it through your thyroidectomy. So, we have your surgical procedure. As you can see here, you have your partial thyroidectomy and your total thyroidectomy. You have to understand that along with your thyroid gland, you also have the placement of your parathyroid gland. So, you really need to be careful when you are facilitating a surgical procedure for that, because it's not just your thyroid gland that you're going to be dealing with, but also your parathyroid gland, which is just placed behind your thyroid gland. So, itong, one of the intervention, surgical intervention, is your thyroidectomy. May it be partial, subtotal, or total thyroidectomy. That is how it is going to be done. And since we are going to be incising and there is invasive procedure there is a possibility for respiratory distress. It's a major operative case, and post-operatively, you might be predisposing the patient to suffering from your respiratory distress or your laryngeal stridor. Kasi nga, close siya doon sa throat mo. Even in your larynx. So, because there is your invasive procedure in that specific area, there's a high possibility that inflammatory reaction or inflammatory response would be highlighted here. So, tracheal edema. Pag nagkaroon ka ng tracheal edema, your tissues in your trachea is inflamed, you are going to be having problems with your respiration, ventilation. So, initially, normally, your sore throat is expected because, you have your invasive procedure in that specific area of your throat or in your anterior throat. Okay? And dysphagia might also be expected. However, if in any case the patient will be complaining about not just your sore throat and even your dysphagia, but already your respiration problems and ventilation problems, dapat you as a nurse should prepare your tracheostomy set at bedside. These are the things that you should be providing to your patient at bedside. If in any case there's an emergency, okay, and that's going to happen when you have your respiratory distress and your laryngeal stridor. So, tracheostomy set should be at bedside because the doctor may facilitate your bedside procedure for your tracheostomy. So, you have there your good light, your source, your oxygen tank, yes, your sterile water and container, you have your suction machines. Actually, for most of our clients in the ICU who have your tracheostomy, okay, it's like a standard. Ito talaga yung mga ginagawa namin. All of these equipment should be at bedside, most especially your manual resuscitation bag and also your tracheostomy set. Okay, your pulse oximeter, that's a standard in the ICU. You have your suction machine, catheters, etc., so that we don't need to panic when time comes that the client suffers from your respiratory distress. Okay, next, apart from that, I did mention that your hoarseness, or maybe your sore throat, by the way, your sore throat is expected, but your hoarseness for a long period of time means something else. That might mean, again, your tracheal edema. So, as a nurse, you need to report that to your physician. So, okay, report that. Okay, maintain sa Fowler's position to reduce edema at surgical site. Kasi nga, kapag nakahiga ka, you're trying to stretch out that specific part which has undergone your invasive procedure. Observe also for your hemorrhage at operative site and at the back of the neck, because sometimes, you had a leakage of your blood, even if you had your OS covering the part which has your incision. So try to touch the back of the patient's neck and see if it's actually moist or if there's blood there. You don't want, again, bleeding to happen because that's another problem that you need to solve. observe for your thyroid storm or your thyrotoxicosis. I've mentioned that you need to have this one as your homework. You have to read this one. Okay? Notify your physician, stat, if signs and symptoms of your thyrotoxicosis. Again, thyrotoxicosis is a complication, the late manifestations of your hyperthyroidism. If there is no intervention for that increased levels of your T3 and your T4, at pinabayaan mo lang yan, ang end result niyan is the complication or the late manifestations of the disease, and we call it your thyrotoxicosis, or you call it your thyroid storm. Kasi talagang sobrang dami na ng T3 and your T4. So if that is the case, what can be done for the patient is to provide your medications. And these medications are, you have your propranolol. You can still remember what your propranolol is? What is the classification of your propranolol? It is your B blocker, your beta blocker, antihypertensive medication. And you also have your PTU, or your propylthiouracil. I'll be explaining this one to you later. You also have your iodine, kasi kailangan na magbigay tayo ng iodine. Naubos yung iodine dahil sa inabsorb lahat ng yung thyroid gland. Okay, so not much is left for you in your circulation. And you also have to provide for your steroids because they are your anti-inflammatory medication. So